Good morning, good afternoon, and good evening to everyone. Okay, I think we have everyone from different parts of the globe today. Okay, so I am Dr. Jomer Maravilla. I'm a research fellow from the University of Queensland and the Queensland Centre for Mental Health Research in Australia, and I will be your moderator for today's webinar. We are very excited to launch the National Adolescent Mental Health Surveys, or NAMHS webinar series. This webinar is co-organized with Johns Hopkins Bloomberg School of Public Health and features speakers from our collaborating organizations in Kenya, Indonesia, and Vietnam. NAMHS involve nationally representative household surveys of the prevalence of mental disorders among adolescents in Kenya, Indonesia, and Vietnam. So the webinar today features 4 speakers: Associate Professor Holly Erskine from the University of Queensland, Australia, Dr. Johannes Dibaba-Wado from the African Population and Health Research Center in Kenya, Dr. Amira Eliza Wahadi from Universitas Gadjah Mada in Indonesia, and Associate Professor Nguyen Duc Vinh from the Vietnam Academy of Social Sciences. So I would like to inform everyone that this webinar is recorded. The link to the recording and additional resources will be sent to the email you provided when you registered. Also, I encourage you all to type in your questions in the Zoom Q&A box during or after each of the presentation. We will ask speakers to respond to your questions when all the presentations are done, where we have allocated around 20 minutes for questions and discussion. Okay, so to kick off our webinar, I would like to introduce our first speaker today, Associate Professor Holly Erskine, Principal Investigator of NAMHS. So Holly is an adjunct associate professor at the University of Queensland and leads the Child and Adolescent Psychiatric Epidemiology and Services stream at the Queensland Centre for Mental Health Research. So I think Holly has shared her screen. So Holly, you may now take the floor.
Wonderful. Thank you so much, Joma. Just turn my camera off. So, look, I'm delighted to be here with my colleagues from Kenya, Indonesia, and Vietnam, as well as Joma from the UQ-NAMHS team. I'd also like to extend my thanks to Professor Bob Blum, Mr. Trevor Arnett, and our team from the Johns Hopkins Bloomberg School of Public Health for hosting this webinar on our behalf. I'm really delighted to be able to speak today about the National Adolescent Mental Health Surveys, or NAMHS, which has really been an honour to be involved in since 2018. So today I'm going to be giving some background on adolescent mental health, speaking to some of the challenges with the data that was available for mental disorders in adolescents before NAMHS. And then I'm going to give a brief overview of NAMHS, including the measures and what we hope to have achieved by conducting this cross-national study. So I guess beginning really back to basics with adolescent mental health. Now, adolescence, as we know, is a critical developmental period, and it's also a critical period for mental health. It's influenced by a range of factors, so things like risk factors such as bullying, substance use, child maltreatment, protective factors as well, such as positive family functioning and parenting, as well as other factors, some as simple as demographics. And we know that poor mental health in adolescence can have significant impacts both now and in future. So thinking about during adolescence, we know it can really impact things like education, which in turn has future impacts on things like economic and occupational outcomes, as well as in both cases, social functioning. Adolescent mental disorders or poor adolescent mental health impacts not just the adolescent themselves, but particularly their family, as well as their community and their broader economy. And something I always like to start off with when we talk about mental health, and this applies to adolescents and all ages, is there is no true health without mental health. So what do we actually mean when we're talking about mental health? Because often the term mental health and mental disorders are sort of used interchangeably, which isn't quite correct, because mental health can be thought of as a spectrum ranging from good mental health to poor mental health. Now, we define a mental disorder by essentially drawing a line at where these sort of thoughts and feelings and behaviours that can often be a normal part of life start causing distress, disability, and either an increased risk of suffering death, pain, disability, or an important loss of freedom. And we need to make a decision about where to draw the line. And that's often, quite contentious, both within mental health and health measures more broadly. And one of the ways we do that is, or one of the measures we use, is the Diagnostic and Statistical Manual of Mental Disorders, which is a bit of a mouthful, but it's the DSM-5. And the DSM-5, I guess, is one of the dictionaries we use to define mental disorders and different mental disorders, both in adolescents and adults as well. And we need diagnostic guidelines like the DSM-5 because mental disorders, diagnosing them isn't as straightforward as some other physical, let's say, communicable diseases. There isn't a blood test that we can use that tests whether or not a person has major depression, yes or no, or at least not yet. So obviously, we do know some things about the prevalence of mental disorders in, the global community. But a lot of the data that we do currently have is limited. And I mean limited in terms of the methodology. So a lot of the data or the studies that we do have use symptom measures. Now, these are important, but they tend to be brief measures of mental health rather than diagnostic instruments that are able to provide a diagnosis of mental disorders according to internationally recognized guidelines like DSM-5. And this is really important because we need that kind of data for in-country service planning and public health efforts, as well as being able to compare across countries. Also, many of these studies, understandably, are conducted in urban centres with existing research structure. And thinking of our I-NAMHS countries, that would be places like Nairobi, Hanoi, or Jakarta. Or they're conducted in specific locations that are chosen for specific reasons. So, for example, there have been a few studies done in Indonesia focusing on areas most impacted by the tsunami. And while these studies can inform local efforts, they generally can't be generalised to the national level to inform, countrywide policy and action for adolescents. Finally, a question we get asked a lot is there is obviously clinical data or hospital data, which does serve an important purpose and is, definitely has its own value. But it can only speak for those who can and who did access services in areas where services are available. And this is a pretty big consideration when we're talking about adolescents whose access to and use of services is generally determined by their caregivers. So all in all, there really is limited data meeting diagnostic criteria. And a 2016 study actually analysed the representativeness of the available prevalence data for mental disorders in children and adolescents. So looking at, okay, of the data that we do have that meets these conditions, what proportion of the global population is represented? And it's actually only 6.7%. And the discrepancy between high-income countries with coverage of 26.4% and low middle-income countries with average coverage of 4.5% is quite stark. And it's even more impactful when you think about that these are the areas, so in lower middle-income countries, these are the areas where most of the world's adolescents live, yet they're the areas for which we have the least amount of data. So essentially, there are three key challenges when measuring the prevalence of mental disorders in adolescents in lower middle-income countries. There's using a diagnostic measure of mental disorders, which adheres to things like DSM-5, but also allows for necessary cultural adaptation. The second is employing a household-based sampling design, so it's representative of the general population on a national scale, so representative of the entire population in the face of varying geographical and cultural and logistical challenges. And then the third challenge is being able to do this in more than one country. So what did we do? Well, these are the 3 challenges that NAMHS overcame during our data collection, as well as many others, one of which, as I'm sure you're all aware, was a global pandemic, which we did not expect. But NAMHS, or the National Adolescent Mental Health Surveys, is a multi-country study conducted in parallel across Kenya, Indonesia, and Vietnam. It includes the 5 organisations listed there, and you'll hear more from my colleagues in Kenya, Indonesia, and Vietnam, as well as further collaboration by ministries of health and other institutions within each country as well. And it's a truly unique study, not just in that it was 3 surveys, but it was actually 3 surveys run collaboratively by 5 organisations working together in such a manner to produce something not just incredibly significant within country, but also something that's actually quite groundbreaking globally. So I'm really, I guess, skimming over the work and the background that went into NAMHS. But NAMHS, as Joma mentioned, is a nationally representative household surveys of the prevalence of mental disorders in adolescents, that's 10 to 17 years in our 3 countries. It involves adolescents and their primary caregivers being interviewed by a trained interviewer. And data collection occurred in 2021, and I have the final sample sizes there. And what I'd just like to mention is those sample sizes actually equate to response rates between 81.1% for Vietnam, 92.2% for Indonesia, and 97.9% for K-NAMHS, or for Kenya, sorry. Those response rates are really high and truly incredible to have achieved, I think, particularly during a global pandemic, with full credit going to in-country organisations for not just pulling off a survey, a nationally representative survey during a pandemic, but doing one with that kind of a response rate to the kind of standard that we all established. And to give you a sense and to get you excited about the richness of data that we have in NAMHS, and remember all of these are multiplied by 3 because we have them for each country, you can see we have a huge range of measures. So in the purple, that's what I'll focus on. Those are our mental disorder measures, which were measured using the DISC-5, or the Diagnostic Interview Schedule for Children version 5. The DISC-5 is a fully structured diagnostic instrument that assesses mental disorders in children and adolescents. It's designed for administration by trained lay interviewers. And by lay interviewers, we mean people who are trained to deliver the DISC-5, but who aren't necessarily clinicians or anyone with health training. So this makes it possible to do on a national scale. Now, what we're focusing on today are 3 of the DISC-5 modules. So we have social phobia, generalized anxiety disorder, and major depressive disorder, or NDD, as we often refer to it. And a question might be asked is, you have all of this incredible rich data. Why are we only focusing on depression and anxiety today? Well, as you can see, even just with the DISC-5 measures, if we were to go through these, we'd keep you all here for about 12 hours. So we thought it was probably best to do a short and sweet, impactful introduction to NAMHS, focusing on anxiety and depression as the best entry point to get everyone excited about this really incredible project. So finally, what is the importance of NAMHS? So why does data like this actually measure, and what is it going to let us do? Well, obviously, it will let us determine the prevalence of mental disorders. It'll also let us identify risk and protective factors that could be the focus of intervention and public health campaigns, which most importantly helps us translate this research into evidence to inform health policy and laws. Because there is no point doing a study as incredible as this, maybe publishing a nice paper, but not actually doing anything with it. What we want to affect is actual change in the lives of adolescents. So NAMHS provides this vital information for both in-country governments as well as international health organisations and global research efforts like the Global Burden of Disease Study, which needs this data to help quantify the burden of mental disorders. And many countries, all of ours included, use GBD estimates to also inform policy. And as I said, that feeds into this cross-national comparison. Also, I'm sure it's been clear from my presentation so far, you've heard how excited I am about the methodology that's been established by NAMHS. And it was built the way it was built so that it could be used in future in any one of our countries, as well as in surrounding regions or similar countries, or even on smaller scales in special populations as well. And finally, most importantly, the importance of NAMHS and the entire rationale for NAMHS is to improve the lives of adolescents, their families, and their communities. And how the data from NAMHS will be actually used to do this and the potential of this data, the plans for this data to make these improvements will be discussed by my colleagues from Kenya, Indonesia, and Vietnam. So thank you very much.
Thank you, Holly, for such a great and informative presentation. I think Holly's presentation gave us a concise yet comprehensive overview of NAMHS, the knowledge and research gaps that NAMHS has addressed. So if you have questions for Holly, and I can see already a couple of questions in the Q&A box. So if you have questions for Holly, I encourage you all to pop it in our Q&A box for discussion later. Okay, so let me introduce our second speaker. So I would like to introduce Dr. Johannes Dibabawada. So Johannes is the project manager of Kenya National Adolescent Mental Health Survey, or K-NAMHS. So Johannes is a research scientist at the African Population and Health Research Center in Kenya. So I think, Johannes, you may now share your screen.
I will be presenting the results from Kenya. As had been introduced by Holly, this was a collaborative study locally led by the African Population Health Research Center for the Kenya National Adolescent Mental Health Survey. We had also collaborated with the Ministry of Health as well as the Kenya National Bureau of Statistics locally, and with the University of Queensland and the Johns Hopkins Bloomberg School of Public Health in the US. So Holly has provided a good background, rationale, and what the survey measured broadly. I will be presenting results for Kenya, and I will focus on the prevalence of anxiety disorders and major depressive disorder as found through the NAMHS survey in Kenya. I will start with a brief introduction of the study design, which has been highlighted well by in the presentation by Holly. As indicated, this is a nationally representative cross-sectional survey that was household-based. And we followed a multi-stage or stratified sampling procedure, whereby we sampled counties in Kenya at the first stage. You can see the green highlighted counties in the map of Kenya, about 14 counties. And then within counties, we sampled enumeration areas with the help of the Kenya National Bureau of Statistics at the second stage. And thirdly, we sampled households after conducting household listing in the sample enumeration areas. So at the end of the day, we ended up we successfully interviewing about 5,155 adolescents, and the response rate was really very high. And we're glad we succeeded in coming up with a huge response rate. This slide shows the characteristics of the study participants, to just give you a highlight of what the respondents look like by gender, age, and school attendance. I will briefly highlight the key findings here. As you can see, about 53% of the respondents were female adolescents of age 10 to 13, so 10 to 17, while 47% were males. In terms of age, we grouped them into 10 to 13 and 14 to 17 years. And as you can see from the bar in the middle, we have about 55% younger adolescents of 10 to 13 years and 45% adolescents of 14 to 17 years. On the right side, you see bar showing school attendance, and almost all or 97% of the adolescents included in the survey were school going. So these are the brief characteristics. The data shown here is unweighted, but all other presentations, data presentations we make are weighted to represent the Kenyan population of adolescents. I now move to the presentation of findings on anxiety disorders and major depressive disorder. This bar shows the combined prevalence of anxiety disorders and major depressive disorders in the 12 months before the survey. As you can see from the bar, the length of the full bar, about 6.79 or 6.8% of adolescents had anxiety disorders or MDD in the 12 months before the survey. And when you look at the two disorders separately, anxiety disorder shown by the bracket on the right side, about 5.63% of adolescents had anxiety disorders, and almost 2% had major depressive disorder in the 12 months before the survey. MDD is shown by the bracket on the top left. You can also see the prevalence of anxiety disorder only or MDD only, but importantly, there is important overlap where adolescents with comorbidity is shown. About 0.85% of adolescents had both anxiety disorders and MDD, the dark bar in the middle. So these are really groups with key challenge in relation to mental disorders. What is important here is that the prevalence of mental disorders is really high, showing that mental disorders is common among adolescents in Kenya. If we try to translate this into numbers, assuming that we have about 10 million adolescents in Kenya, this translates to about 1 in 15 adolescents with combined anxiety disorders and MDD, or equivalent to about 700,000 adolescents, or about 18 adolescents with anxiety disorders, which translates to close to 500,000 adolescents with anxiety disorders, and about 1 in 50 adolescents with MDD, which is equivalent to about 200,000 adolescents living with MDD in Kenya as at the time of the survey. So we can see that the mental disorder of interest to this study are really common and very serious. On the right side, you will see variation in the combined prevalence of mental disorders, specifically anxiety disorders and MDD by sex and age. As you can see from the horizontal bars, comparing male and female, females have slightly higher prevalence of combined anxiety and MDD disorders, but the difference is not statistically significant. On the lower side, you see differences, a comparison of prevalence by age. As you can see, older adolescents had slightly higher prevalence of anxiety disorders and MDD combined as compared to younger adolescents. But again, the difference was not statistically significant. We did a separate analysis for the two disorders and found that the prevalence of MDD varies significantly, showing that older adolescents had higher prevalence of MDD as compared to younger adolescents. Next, we will look at the prevalence of suicidal behaviors and self-harm. The survey also collected data on suicidal behaviors and self-harm. Suicidal behaviors here on this slide refers to the percentage of adolescents who had a suicidal plan or making a plan to end one's life. We also collected data on attempted suicide, suicidal ideation, but we only show one indicator here. So as you can see from the bars, the dark bar shows the prevalence among the whole sample. About 2.4% of adolescents had a suicidal plan in the 12 months before the survey. But this rises to about 14.4% among adolescents with anxiety disorders and or MDD in the 12 months before the survey. On the right, we have self-harm. By self-harm, we mean the percentage of adolescents who deliberately try to harm or injure themselves without really trying to end their life. About 1.2% of adolescents reported trying to self-harm themselves in the 12 months before the survey. This is for the whole sample, but this rises to about 5% for adolescents with anxiety disorders and MDD. So you can see that adolescents reporting anxiety disorders and MDD were more likely to report suicidal behaviors and self-harm, in showing the association between mental disorders and suicidality. Lastly, we will highlight the implications of the study. As Holly earlier said, this is really the first national survey of adolescent mental health that showed the prevalence of mental disorders, different mental disorders, risk and protective factors. We hope that this fills the huge data gap that we have that has limited researchers, policymakers, planners from making public health efforts or developing plans, policies to improve adolescent mental health. So this study therefore provides an important evidence base for policy and health initiatives in Kenya and beyond. Secondly, the data on the prevalence of mental disorders and suicidal behavior highlights the need for early prevention, diagnosis, and treatment of mental disorders. It's known that undiagnosed and untreated mental disorders have serious long-term consequences. So it's really important to have programs that address mental disorders early on. So implementation of specific screening and management strategies within the broader framework of mental health promotion programs is needed. This can be implemented within the school setting. As we showed earlier, almost all the adolescents, 97% were in school. Another implication is that the study, our findings would also contribute to the discussion around the decriminalization of suicide in Kenya. In Kenya, sadly, suicidal attempts is a crime. So someone who is found attempting suicide may be subjected to a jail term of about 2 years. So, but this study showed that suicidal behavior, suicidality is really a health problem, and it's not about a legal issue. So to reduce suicidal behavior is also important to improve the mental health of adolescents. Lastly, the findings also indicate the potential opportunity for making more targeted interventions, particularly for groups that are more at risk. As we indicated earlier, the prevalence of MDD was higher among older adolescents. So designing programs that focus on MDD management strategies is really important. So in short, this is a presentation. Thank you very much. I stop here.
Thank you, Johannes. So I think Johannes has shared a lot of informative information about K-NAMHS findings, and he also made those direct links between the data from K-NAMHS and its potential impacts on policy, such as the criminalization of suicide. I think people are popping in a lot of questions, which is great. But again, I would like to encourage again all of you guys, if you have questions, thoughts, feedback about Johannes as well as Holly's presentation, please put it in the Q&A box. Okay, so now I would like to introduce our third speaker, Dr. Amira Eliza Wahadi. Amira is the project manager of I-NAMHS, or the Indonesia National Adolescent Mental Health Survey. Amira is a public health physician and is based at the Center for Reproductive Health at the Universitas Gadjah Mada in Indonesia. So I think Amira has shared her screen. So Amira, you may now take the floor.
Yeah, thank you, Jomer, for the introduction. I'm so glad to be here. Hello to everybody. And I'm here, as Jomer has mentioned, as a representative from I-NAMHS. I serve as the project manager of I-NAMHS since at least the beginning of the project, at least since 2018. So a little bit before we move to the heart of the story here, just a little bit about Indonesia. We are an archipelago, which will play an important part later on. And this is currently the fourth biggest country in the world with 270 million people. And because of that, we at UGM, it was impossible for us to do this alone. In fact, we have two partners, university partners. One is Universitas Sumatera Utara, which located in Sumatra Island. You can see it in the left side of your screen. And we also have Universitas Hasanuddin in South Sulawesi. You see an island that looks like letter K. South Sulawesi is located there. So three of us, along with the Ministry of Health, has been working together since the beginning of I-NAMHS to make sure that we can conduct this, we can conduct this study at the highest standard possible. And a little bit, of course, about our sample characteristics, the demography of our participants. We, in total, we have 188 enumeration areas that covers all of the country. At that moment, Indonesia had 34 provinces. And we have 5,664 households participated in I-NAMHS. As Holly already mentioned, it means that in each household, we interviewed the adolescent and also the primary caregiver. And for you that it's that are familiar with Indonesia, you can see here that the characteristic of our sample is basically more or less similar to the wider population for this age group. That most of them are attending school at a time. This include online school because of COVID, and not working. So they're as adolescents, they spend most of the time studying. So now we move to the core of our webinar here. So based on I-NAMHS, we report that the 12-month prevalence of anxiety disorder and MDD among 10 to 70 years in Indonesia is at 3.72% and 1.02% respectively. We also see here that around 0.63% of Indonesian adolescents has both anxiety disorder and MDD. Overall, 4.11% of Indonesian adolescents in this age group, 10 to 17, had anxiety disorder or MDD. When we dissect this data further, we see here that there is a difference in anxiety disorder and MDD prevalence between male and female, with female having a higher prevalence, but this difference is not statistically significant. We also see here that the older age group has a higher prevalence of anxiety disorder and MDD, and this difference is statistically significant. We also look at self-harm and suicide behaviors. We see here that adolescents with anxiety disorders and or MDD have a higher prevalence of both self-harm and suicide behaviors compared to the whole sample. Whole sample meaning that the whole survey population, including the one here with anxiety disorder and MDD. So what does it mean? So if we talk about numbers based on I-NAMHS, we can say that 1 in 25 adolescents in Indonesia has anxiety disorder or MDD. This equal to 1 million adolescents if we refer to the latest census in 2020. And just to give you some description here, considering that one standard classroom in Indonesia is roughly around 30 to 40 students, we can estimate that at least we will have one student aged 10 to 17 years old with anxiety or anxiety disorder or MDD in any classroom. And what does it mean, right? If we say that 1 in 20 adolescents will have this condition or disorders, what is the reality that we see in the field? Despite the alarming number, we can say that in reality, not everybody, not all adolescents can access help or even have an acknowledgement or receive diagnosis about their mental health condition. So we will leave it that now and just move to the fact that at least now we have first national numbers on adolescents, anxiety, and depression. Referring back to what Holly already mentioned about the strength in our methodology, this survey is really a breakthrough in our mental health epidemiology in Indonesia. So we then move again to the numbers. Now we have the numbers, and we can say that anxiety and depression are common among Indonesian adolescents in this age bracket. And because we see a discrepancy between the number that we have, the number from I-NAMHS and the reality in the field, it seems that there should be more effort to increase community awareness about mental health, to educate not only adolescents, but also other related stakeholders about the importance of mental health, so the adolescents that are asking for help will get the assistance that they need from their surroundings. And it's also important to mention that anxiety and MDD are internalized disorders, so it might not look clear for people around the adolescents, but the fact that adolescents experience this kind of problem or disorder are not something that we can just neglect. So more community awareness, and eventually also to address the stigma about mental health in Indonesia context. And it also touch base with, related to the health system readiness to conduct effective promotion, prevention, and early detection and treatment programs. Based on what we learned from I-NAMHS, some regions in Indonesia already started to implement this, particularly at school, because most of the students, the adolescents spend most of their time at school. So it means that they start to link schools with community health centers, and also targeting teachers and parents as a part of their intervention, whether it's for promotion, prevention, or early detection. This is what we call by low-hanging fruits. So things that we can do immediately without really rely on some big changes in the government system or government budget, or even change in regulations and policies. So things that we can do immediately that's close to the adolescents, and also putting adolescents in the center, at the center of the intervention or programs that we create for them. It means that we need to listen more to them. During I-NAMHS, also, of course, like Polly already mentioned, also that at this moment is not analyzed yet, but it seems but we want to go there. So we want to look further into what kind of support that adolescents need. So I-NAMHS is also contributing to that. And reforming mental health in Indonesia will take time, of course. So particularly for our efforts to produce trained psychiatrists and clinical psychologists in Indonesia. Currently, most of trained psychiatrists and clinical psychologists, especially the ones that train in adolescents, are concentrated in Java Island, which is, one small islands with, yes, the biggest population in the country, but it means also adolescents in Sumatra, Kalimantan, Sulawesi, and Papua will face barriers, layered barriers, just to access mental health care. And this is something that we need to put on the front of our minds while talking about adolescents' mental health in Indonesia. The survey also proves that with collaboration, it is possible to conduct a survey about mental health among adolescents. There is growing attention on adolescent mental health in Indonesia, and despite the stigma, I-NAMHS show a good response rate. We have response rates around 98%. And my personal hope is that this is not the last national survey on adolescent mental health in Indonesia. In affirming Indonesians' commitment to investing in adolescents' mental health, we will obviously need to monitor this number to evaluate whether we are doing enough or not. And this is all that I can share for now. I'm looking forward to any questions or comments from you all. And yeah, I refer back to Jomer.
Thank you. Thank you, Amira. Okay, so I think Amira really gave us a good overview of anxiety and major depressive disorder in Indonesia. And I think she also outlined important implications for health promotion, mental health workforce, and community awareness. I'm sure that those discussion points or talking points will generate a lot of discussion later on. And I think I can see from the chat box as well, a lot of people were putting in questions, which is great. So yeah, really, really exciting. Okay, so for our final speaker will share his findings from V-NAMHS, or Vietnam National Adolescent Mental Health Survey. So Associate Professor Nguyen Duc Vinh is the project director of V-NAMHS, or again, Vietnam National Adolescent Mental Health Survey. He's based at the Institute of Sociology within the Vietnam Academy of Social Sciences as the current director. So now, Vinh, you may now share your screen and start your presentation.
Okay, thank you for introduction. Hello everyone. I am very honored to be here on behalf of the V-NAMHS to present some findings from this very important survey. So as Holly has introduced some very important information about the project, so I would like to inform some information about specific for Vietnam. For Vietnam, the V-NAMHS is the first national representative survey on adolescent mental health in Vietnam. So we might have some very small area or small group of people, but that is the first nationally representative survey on mental health in Vietnam. So in sociology, in cooperation with the General Office for Population and Family Planning from the Ministry of Health, conducts the data collection for Vietnam from September to December 2021. We also cooperate with some experts from the General Statistics for sampling design, and so some experts from Ministry of Health for the development of the survey tools. And in total, we the survey completely interview nearly 6,000 adolescents and their primary caregiver from in 200 enumerated area across 38 provinces in Vietnam. In Vietnam, we have 63 provinces, and the survey select randomly 38 provinces for the data collection. And the distribution of the adolescents interviews, including about 52% male and 47 female, and 45 46 is 10 to 13, and so 54% is from 14 to 17. From the map, you can see that's the province with the red star that's the province for the survey. Such that distributes very widely in the country. And here is means estimate for the anxiety disorder and MDD, major depressive disorder among adolescents from 10 to 7 years old in Vietnam in the past 12 months before the survey. You can see that the percent of MDD is 0.85%, and percent of facing anxiety disorder is 2.26%. Only 0.4% of them have both of the disorder. The percentage look quite small, but if estimate for the whole population, then it corresponds to about 2,064,000 adolescents with anxiety disorder, and about 99,300 adolescents with MDD among the population as 10 to 17 in Vietnam in 2021. Similar to in Kenya and also in Indonesia, so they are slightly different in the field estimate by gender and so by age, but the difference is not statistically different. That means that there is the problem of anxiety disorder and MDD is might not be for some specific group like male or female or younger or older adolescent, but maybe as a universal issue in the adolescent in Vietnam. So next is look at the correlation with association between anxiety disorder and MDD, and the suicidal and self-harm behavior in adolescents in Vietnam. You can see there's a very clear association. If you look at the percentage of suicidal behavior among the total sample, only less than 0.4%. But among the adolescents who have the anxiety or disorder or MDD is more than 10% high, 10 times higher, about 5.4%. So different also even higher in self-harm, because for the whole population, only 1% the adolescents have the self-harm in the past 12 months, but for the group with anxiety disorder or on MDD, the percentage is as high as 10%, about 10 times higher. So that is some discussion. That is very, I think it's a very primary analysis of the data. But also I want to discuss some about from the estimates. So V-NAMHS, that is the first national survey, and it provides very new and reliable estimates and evidence. We believe that it's very useful for further development of relevant public health policy in Vietnam. If compared to some other previous survey and study in Vietnam, they provide some estimation, and our estimates here is not very high, but to compare with previous estimates, weak only for smaller group in Vietnam with different methods. but still, anxiety disorder and MDD appear to occur in any group or adolescent, not just a few specific groups. And with nearly 14 million adolescents in Vietnam, these are very critical public health issues that request more attention, especially in the current context of Vietnam, which offers a very limited public awareness and poor mental health service system. Having said so, I want to inform that within the population in Vietnam is well known to be the with a relatively high life expectancy, but quite low healthy life expectancy. Knowing that, the government has focused also switched population strategy from focusing on primary healthcare to improving the quality of population. And among them, I think the mental health is a very important aspect of quality of population. Then recently, because that, then the government and the Ministry of Health also have been paying significant attention on the issue of mental health. For example, recently in December 2022, the Ministry of Health issued a circular on mental health care tasks for health facility until the community level, from the very high level to the community level. That means that before that, then the community levels of the healthcare facility didn't have the mental health care task. However, this will be fully implemented at the end of 2028. And the second is in the August 2022, the Ministry of Education and Training also provide issue a plan for mental health education for children and students in the periods 2022 to 2025. This is just two examples that the issue of mental health has been paid more attention by the Vietnam government recently. But still, the government and also the military, they know the important issue. They know that what they should need to achieve. But still, they still lack of a lot of lack of information. Especially information from the survey like the V-NAMHS to clearly address the mental health issue and how to implement the policy effectively, how to achieve the goal. So they need information for development of this kind of policy. And there are many options they can do. For example, they can improve the early detection and treatment circuits. And so for minimize the negative consequence. Then, as we can we see I can see on the previous slide as a very close association between the Switzerland asthma and the MDD and depression disorder. Then I think if they can improve the early detection and treatment service, that can obtain many short-term and long-term benefits. So they can also the policy also can focus on improving the understanding of anxiety disorder and depressive disorder, and also how to identify symptoms and how to seek help, and especially in family and school setting in Vietnam. Once again, I want to emphasize that the government has determined the basic issue and goal, but has been lack of specific effective solution for achieve them. Then I hope and we plan to have in-depth analysis of from the V-NAMHS data, not only on anxiety disorder and MDD, and also as an aspect of mental health of adolescents in Vietnam. And hopefully we can provide more evidence and also solution for the development of the policy in Vietnam. Thank you. I hope looking forward to have feedback and the comment.
Yep. Thank you, Vin. Thank you so much for your presentation. Thank you also for, I think Vin touched on how V-NAMHS is positioned to contribute to the continuously evolving policy landscape in Vietnam. So, yeah. So I think in summary, before we jump straight to our Q&A, I think I just want to say that our speakers today were able to provide an overview of NAMHS, how it was implemented, just very, very brief information about how it was implemented in the 3 different countries. I think the quality of information presented today demonstrates the rigor of NAMHS in all 3 countries, the strong collaboration of the 5 institutions from different parts of the world, as well as the successful engagement, as you can imagine, with local stakeholders, which made K-NAMHS, I-NAMHS, and V-NAMHS possible. We also heard from the speakers about the prevalence of anxiety disorders and MDD, and most importantly, we got a sense of what these findings actually mean in each country, how they can contribute to improving adolescent mental health. So now moving on to our Q&A, I think I would like to just, acknowledge our speakers today for diligently answering the questions from our audience today. I can see a lot of questions from our audience today. I think with the amount of time that we have left, I think I would just like to ask our speakers to respond to 2 questions that I thought are worth discussing further, sharing their thoughts on. So the first question is, I think this is from Maria. So Maria asked, what were the main challenges faced during data collection or during collection of data? And regarding the participants and use of the questionnaires that would lead to bias, any common challenges that you would like to share? And I guess if I would like to add, like, how did you address these challenges or mitigate the challenges? Yes, sure. And also just a reminder for our speakers, if they can turn on their camera so that our audience can see you while you're answering the questions or sharing your thoughts about the question. So, yeah.
Thank you. That's an interesting question. In each of the 3 countries, and specifically in Kenya, where we implemented the survey ran for 2 to 3 months or even longer for various reasons. One, this was during the COVID period. So we had to observe all COVID guidelines, do it carefully. Sometimes when COVID recurs, we had to pause for some time. So we really had challenges due to the pandemic. The second is a local context. For instance, in Kenya, we did the survey while adolescents were in school. So sometimes you had enumerators had to wait until the adolescent come back from school and interviews done in the evening. Some counties rain, even local bit of insecurity and so many other factors contributed, but we had to patiently do it. And that's how it ran for up to 3 months or more. So quite a number of challenges, but we overcome. Thanks.
Thank you, Johannes. Does anyone want to add anything from what Johannes has discussed? Amira or Bin?
Yeah, well, pandemic was definitely a problem, but we, at least in Indonesian context, culture was the main not challenge per se, but something that we needed to work very delicately, because we are a diverse country, and we did employ local enumerator. So the enumerators were really familiar with the culture and how to ask the question in a correct way without, making the participants or their parents angry. But it also made there is a fine line that we need to really work on to balance that cultural aspect with our standard based on the methodology, and how to make sure that we were asking what we wanted to ask. So yeah.
Thank you, Amira. Vin, yeah. I can see you're unmuting. So yeah, Vin, do you want to share your thoughts?
I think the V-NAMHS has faced similar challenges as in K-NAMHS, also I-NAMHS. But especially for the COVID-19 pandemic, we face serious problem with that, because from the beginning, we planned to carry out a survey in early 2000, in the summer 2000. But because of COVID, and we estimate, although that the COVID pandemic will be over after 1 year, then we decide to delay it for 1 year to summer 2001. But that time becomes the pandemic became very serious in Vietnam, and we face a lot of difficulties, and we have to work very closely with the local people, collaborator, to work in the COVID time, and because the COVID situation changed a lot, then we not allowed to carry out survey in the area with a high level or medium level of COVID-19. Then we need to work very hard to overcome it. And the second issue is similar to the I-NAMHS. The health, mental health is including a lot of new concepts, not only for the population, for the children, but also for the people like us. Then we need to take a lot of time to convert it from from the idea, as well as from the research tool from English to Vietnamese, and how to keep the same meaning and everything. So it took a lot of time for us, and I think finally we achieved it. And I think that is the most important issue, most serious issue for challenges for us to carry out the survey. And so some new techniques is first time applied in Vietnam.
In Vietnamese context.
Yes, Vietnamese. We have carried out a lot of survey before, but many things are still very new for us in doing this survey. Sorry,
Holly, sorry, I just saw Holly's she unmuted herself. So Holly, do you want to add or share anything as well?
Yeah, look, just very briefly, because I know we are over time, but I guess I just wanted to touch on the challenge and the learning from the perspective of coordinating NAMHS across the 3 countries as well. Obviously, the COVID-19 pandemic was unprecedented. It really hit about 2 weeks before our K-NAMHS team was due to go into the field in March 2020. And there was no roadmap. There was no precedent for how you deal with doing research, or even how you delay research due to a global pandemic. So it was unprecedented, but at the same time, really up until that point, everything that we had been doing for NAMHS always felt unprecedented. We were always breaking new ground. We were always writing new protocols because there wasn't ones that existed that met our survey needs. So really, when COVID hit, arguably we were a project who was really well equipped to deal with it because we were very used to dealing with new things and unknowns. And I guess I just want to flag that, you know, really what enabled NAMHS to be so successful was the unique collaboration between 5 countries. And not just a collaboration, but, you know, a true, I think, investment by everyone and all the individuals working on it to get it done. So for me, one of the big learnings and challenges, but also learnings, was the real value of the people who you work with and the people who you collaborate with, because that's how you can get through, at the time, what seems impossible. Thanks, Jerma.
Thank you, Holly. I think just one more question for all of you guys. I think it's touching on, again, the challenges, but also how did you, especially those from who administered or implemented the surveys in each of the country, how did you manage the stigma around mental health as you were administering, for example, the DISC-5 and other modules of the service? As you can see, you know, there might be, are there any issues about participants disclosing? How did you deal with stigma? I think one of our participants asked about, you know, how did you address those challenges in terms of engaging participants as well as the parents, adolescents as well as the parents? Does anyone want to respond to that? Johannes? Want to,
yes, I can start.
Yeah.
I think that's a good question. I typed on the chat a brief response to that. I don't think we avoided the influence of stigma at all, but we have tried to reduce as much as possible responding to the questions. First of all, I think there is increasingly people are talking about mental health these days. And respondents were open in discussing issues about mental health with survey respondents. In addition, we have seriously followed all ethical procedures required for mental health research, including ensuring proper privacy. Even for the adolescents, parents would not be able, were not present. So this is strictly private interview. And we also ensured that all information collected will be strictly kept confidential. So those procedures have reduced the influence of stigma and fear of talking about mental health. In addition, at the community level, we really, at high level, we really started talking to leaders at the different level, including at the enumeration area level, that we are conducting a study on mental health, engaged with them, so that broadly people are aware of what we are, the survey we are conducting. Yeah.
Thank you. Yeah, thank you, Johannes. Just because we are lacking time for Q&A, just one more. Any response from one of our speakers today? Holly, Amira, Vin, want to add anything?
Well, just
Amira?
I think, yeah, from our end, we of course try to be what I want to highlight is one of our strengths is because we have a set of ground rules, so to speak, in our protocol. So everything is based on that. So with this bias and how to respond if there is some conditions or participants that reacting so strongly with our survey, we already have that laid out. So enumerators have this. It was taught during their trainings, and there was constant communications between not only UQ and UGM, for example, but also UGM and our partner university. And in each university, there was also a set of governance there that will ensure what's going on in the field will be based on the protocol that we have.
Yeah. Thank you, Amira. Thank you for highlighting the importance of having protocols in place. So I think we're close to the end of our webinar today. Thank you, everyone. Thank you to our audience for such being an active audience. I really love seeing people interacting, at least via chat box. And again, thank you to our speakers as well for diligently responding to the questions of our participants, our audience today. Again, thank you, Holly, Johannes, Amira, and Vin. Just a few reminders. So over the next couple of days, everyone who registered today will be provided with a link to the webinar recording. So you all will get the webinar recording through a link, as well as the links to where you can access and download NAMHS country reports and related publications. And I think in that link, you'll be able to see the contact details, i.e. the email address of our speakers today, particularly the project managers and directors of each countries. We will keep you informed of the next of the schedule of our next webinar via email and our social media pages. So please subscribe to our social media pages. And as we close our webinar again, I would like, in behalf of the NAMHS team, I would like to acknowledge Mr. Trevor Arnett and Professor Robert Bluth from the Johns Hopkins Bloomberg School of Public Health for co-organizing and hosting the first webinar in the NAMHS webinar series. So again, thank you everyone for coming, and enjoy the rest of your day or your evening. Thank you.